Yes, good evening everyone from Pakistan. Yes, Bismillahirrahmanirrahim. Uh, I am Dr. Syed Rameez Haider, working as a final year resident in King Edward Medical University. And I would like to thank the organizers and, of course, my head of department for giving me such an opportunity to present in this IPSRG group. Limb injuries require upgradation from time to time, for which various novelities have stepped forward, and nerve injuries are worth considering in this regard. So, the topic I brought for you guys today is 5 reliable nerve transfers for the treatment of isolated upper extremity nerve injuries. It's basically a review article that has been written by Mr. Peters and his companions from Ohio University, and this article has been published in PRS in 2021. The outline of my presentation falls in principles of nerve transfers, its indications and advantages, and the isolated motor nerve transfers, with some discussion over the important areas of sensory nerve transfers in hand, followed by panel discussion, question and answer session, and in the last we will have a take-home message. Every procedure has its principles, just like similarly, nerve transfers have some principles which we are going to discuss here. Expandable. The donor should have an expandable nature when we are considering nerve transfer. It should have a synergistic function in regard to the recipient nerve. Timing is more important when you are considering nerve transfer, as in this regard, if it's about from 1.5 year to 2 years maximally, as the motor end plates remain not viable if the timing exceeds beyond this time limit. Intraoperative assessment is much more easier with the new gadgets. As you know, with the help of nerve stimulators, these transfers are making our life easier. Tension in both in coaptation and the nerve transfer, as well as in the surgeon's mind, is not so good. So your transfer and the coaptation should be tension free. And in the last, the post-operative re-education with the help of physical therapists, it's more important in the success of successful nerve transfers. Some common indications of nerve transfers are when there is a more proximal nerve injury and the nerve has to travel a lot to reach its targeted muscles. And when there is no proximal stump available, so it's basically indicated that you are allowed for the nerve transfers. When there is a significant scarring, so there is you can avoid, and you are trying to overcome that scar field, so you can choose and opt nerve transfer options. When there is a neuroma in continuity, and of course when there are multi-level nerve injuries such as gunshot wounds and just like other injuries, so when the primary repair is not possible, so nerve transfers can be chosen. Some advantages of the nerve transfers. Why we are choosing the nerve transfers? So, first of all, the regeneration is closer to our targeted muscles, and the length of the graft and avoiding the nerve grafts is the most important benefit of the nerve transfers. And with the nerve transfers, we are able to restore the functions just like motor as well as the sensations in our upper limb extremities injuries. And you can have, of course, as we have already discussed, you can bypass the scarred intervening area. some perioperative and postoperative considerations that author has mentioned in this article is the use of nerve stimulators, on-table assessment for the donor as well as the recipient nerves, uh, that makes the transfer time less and you can have a much more easier assessment. Then avoidance of the local acting depolarizing paralytics and the local anesthetics in the evaluation phase is recommended by the author. And tourniquet time cycle is variable and it varies between less than 30 minutes, and well, it depends on your expertise that what you are going to do, and if you are able to dissection, if you are able to perform the dissections in less than 30 minutes. So it's depend on the surgeon's choice and surgeon's uh, interventions. The post-operative minimization of the immobilization is also considerable while we are considering the nerve transfers. Our first nerve transfer is the median to radial nerve transfer that has been mentioned in this article. So, what are the deficits? The deficits with the radial nerve injuries are the reduced power grip strength, and our goal of this nerve transfer is to achieve the simultaneous wrist or independent finger extensions with reliable, without reliable tenodesis effect. So what are the donors and the recipients for this nerve transfer? The author has chosen the branch of the flexor digitorum superficialis for the nerve to the extensor carpi radialis brevis, and branch for the from the flexor carpi radialis from the posterior interosseous nerve. The surgical technique that has been mentioned in this article is the author choose a curvilinear proximal forearm incision for this nerve transfer. With this incision, he is able to achieve uh, the exposure of these nerves. The radial artery serves as a landmark, so you can proceed with the help of the radial artery. So it's able to follow the course of the superficial branch of the radial nerve. You can able to expose the radial nerve. The decompression of the donor and the recipient nerves is much more important when you are performing this surgery, as this is making the coaptation easier. After exposure, the recipients and the donors are transected and transports towards each other. So the author has recommended this coaptation under the microscope. The postoperative care regarding this nerve transfer includes if the tendon transfer, the author in this article, the author has also performed, reported some case series in which they have transferred the tendon of pronator teres to ECRB. So if that transfer is not done, so immobilization in this kind of transfer, nerve transfer, is not required. The post-operative motor re-education begins at the 4th week with the direction of course, hand therapist, and with the synergistic wrist flexion exercises are initiated for this nerve transfer by 6 to 8 weeks. There has been mentioned a few of the studies. First one is Ray and McKinnon. They have reported 19 patients for this nerve transfer, and they have achieved a good and excellent results for the wrist extension. They have achieved MRC grade 5 in wrist extension in one patient, as well as for the finger and for the fingers extension. And another study is from the Gracia Lopez et al. They have reported 6 patients and they have achieved also good results. Our next transfer is ECRB branch to AIN transfer. So what is the deficit and what is the loss when there is a median nerve injury? So there is a loss of grip as well as a pinch strength, and the patient is suffering from these deficits. So our goal of this nerve transfer is to restore the grip and the pinch strength, which is afforded by finger and thumb. as well as ideally this nerve transfer is performed. It is recommended by the author that this nerve transfer is performed in less than 1 year after the diagnosis. Another donor branches that has been mentioned for this nerve transfer is a branch from the brachialis and the branch from the brachioradialis, peroneal arteries, as well as a branch from the supinator. The surgical technique related to this transfer is the same as we have discussed earlier. The author has preferred a curvilinear proximal forearm incision for this nerve transfer, and he achieved and performed the decompression of the recipient and the donor nerves as this nerve transfer makes it easier. So he choose the ECRB branch other than these donors, as the reach of this nerve is much more easier to the recipient nerve. Regarding postoperative care of this nerve transfer is wrist immobilization is recommended for 3 to 4 days or 3 to 5 days for tissue rest, and hand therapy resumes after the 2 weeks postoperatively. And of course, for the synergism and the good synergism, we have to educate our patients, and therapy starts with the donor strengthening, then activation of the wrist extension, followed by the finger flexion. A few of the outcomes that have been reported related to this nerve transfer is Bertoli and the colleagues, and they have reported the 4 patients who achieved full finger flexion with this nerve transfers. And the MRC grade has been reported 4 out of 5 strength in more than patients compared to the alternative donors. And there is also no evidence of weakness or the radial deviation in the wrist extension has been seen so far in the literature for this nerve transfer. Well, we are choosing the ECRB branch. The next 2 transfers that has been mentioned in this article is the distal AIN to ulnar motor nerve transfer, and the author has done this nerve transfer in end-to-end fashion as well as in end-to-side fashion. And of course, the goal of this transfer is the restoration of the ulnar intrinsic hand function. And when we are following our patient, so primary repair is not possible in proximal or the higher ulnar nerve injuries when the nerve has to travel a lot and motor end plates may not be viable with these time procedure. So we can prefer this AIN nerve transfer over towards ulnar motor nerve transfers. And author has also recommended this nerve transfers for the devastating ulnar nerve injuries as well as compression neuropathy and as well as the complete transaction injuries. So the author has also supercharged this nerve transfer in the compression neuropathies and in the minor cases. The surgical technique for this nerve transfer that author has chosen incision over the distal wrist in the Brunner fashion, that is exceeding proximal in the proximal forearm, and of course with the help of the exposure to the pronator quadratus and achieving the exposure of the anterior interosseous nerve. He is also performing with the exposure of the ulnar motor nerve branch. So this transfer is much more easier when we are considering the full decompression of the donor as well as the distal and the recipient nerves. The outcomes related to this nerve transfer is also excellent. A study reported in this article is by Dunn et al., and they have also reported in 78 patients that has been this nerve transfer has been done in supercharged end-to-side transfer, and overall the patients has rapid return of the intrinsic hand functions with an average of 3 point or at least 3.7 or 4 months. Grip and key pin strength improved 200 by 2% and in 179% respectively. And the disabilities of the arm, shoulder, and hand questionnaire score, they have reported that they have shown the improve with this transfer. Only 8% of, they have reported that 8% of patients did not recover the functional intrinsic muscle hand functions. Sensations are also important when we are talking about the upper extremity injuries. The most important and the critical areas of the hands have to restore first of all when we are considering the sensory nerve transfers. In author experience, sensory transfers in hand will reliably restore the protective sensations. And for the first web space sensation, which is the most important area when we are considering the sensations of the hand, he choose uh, fourth web space fascicle, as well as for the third web space fascicle, he choose the fourth web space fascicle from the ulnar branch. The surgical technique that has been described by the author in this article, he chose a carpal tunnel incision over the ulnar aspect of the thenar eminence, and which is exceeding over the distal wrist crease in a Brunner style incision. And by incising in this pattern, he is able to expose the first and the fourth web space. And by identification of the median nerve fascicles, the donor fascicles of the ulnar nerve to the fourth web space is identified and transected at the level of the metacarpal heads, and the cooptation of the fourth web space fascicle of the ulnar nerve to the fourth web space can be done in either way, in the end-to-end or end-to-side fashion. The outcomes regarding sensory nerve transfers has shown good results, but the literature over these nerve transfers is very limited, and the author experience over the nerve recovery of the sensory nerve transfers, they have reported the protective sensations are achievable, but the poor measurable sensations by 2-point discrimination test. A study reported by Brunelli and his colleagues over the sensory nerve transfers in 21 cases, and their outcomes are achieving the S2 in 9 cases for the sensations of the hand. Thank you. And then we have our expert opinions and from our panelists, and we have time for the question answer session.
I think a very useful and a very comprehensive review of nerve transfer. It was a very good choice, good selection of article for the journal club. Any questions from the audience? Professor Mustahsan, your expert opinion?
Yeah, thank you very much, Dr. Zia. The purpose of presenting this article was that often the residents, they find it difficult to decide about the nerve transfers and a comprehensive review where they can, which they can refer to. So I think overall in this article, the authors have tried to review the literature available on nerve transfers. And the important concepts which I think residents should take from this presentation is that always median and radial, they are like from median to a radial we transfer, and from radial to median, and almost same nerve transfers. The deficit in radial is replaced by the same nerve transfers from the median, which is replaced by the radial for median. So these are few important points which they can remember for their exam. And for any resident or any senior uh, uh, colleague who wants to start with this, there are good videos available along with this article. You can see these videos and he can review the techniques. And overall, I think there are few limitations of this study, that obviously the literature review related to other studies regarding outcome is not very extensive. But overall, the author has referred to the studies which have been published by the experts in nerve transfers. So that makes it quite applicable to our own practice. We see such patients. One question is always asked by the residents about nerve transfers for radial nerve. And in this article, even the author has still recommended the tendon transfer for wrist extension. So that masks the recovery, but it is almost always recommended in almost every nerve transfer for radial nerve to go for a simultaneous pronator teres to ECRB muscle transfer for an internal splint. So, but overall, I think the advantage of nerve transfer over the tendon transfer is that independent movement of the finger extension can be achieved. So I think that summarizes the points mentioned in this article.
Thank you very much. And I think we can move to the next article. And if anybody has questions, they can even ask later.
Yes,
There is a
sure, sir.
question from Siddharth. What
I
is
would
the
like
period of
to
time when?
thank you for giving me opportunity to the host, and I would like to share a take-home message at the end there
Yes,
regarding the nerve transfer. That is the follow the mantra, donor distal and the recipient proximal, and to maximize the functional outcome in patients with nerve injuries, the treatment should be individualized to the patient and the principles of the nerve transfers, as well as the post-operative re-education of the patient with the help of our physical therapist colleagues is the key to success. Thank you very much.
correct. There is a question as well.
Yes, sure, sir.
Sebastian is asking what is the period of time when we can do nerve transfer for ulnar, median, or radial nerve, and we should do tendon transfer. What is the cutoff time when we should stop doing the nerve transfer and then resort to tendon transfer?
So, if I would answer this question, traditionally what is mentioned in the textbooks is 6 to 9 months for nerve transfer. But recently in OPD, I saw a patient where the patient has a brachial plexus injury and shoulder abduction and elbow flexion has recovered. Even the wrist extension has recovered. The median nerve function has recovered, but there was still deficiency of small muscles of hand supplied by the ulnar nerve. And he was still having weakness for the last 10 months, and there was no further improvement in the small muscles of hand function. So it was almost 2 years old injury. But when we had his electromyographic studies, EMGs, so there was motor unit action potentials in the first dorsal interosseous and in the abductor digiti minimi. So it means that the time period was now 2 years, but still the end muscles were still being innervated by the ulnar nerve, though it was not completely recovered. So even in this case, there is an indication for nerve transfer. So it is the timeline is a relative in nerve transfer, though it is recommended that it is 6 to 9 months. But if the distance is very close to the end organs and even 10, 12 months or even 2 years have passed, as I have just described an example, so still you can go for nerve transfer. So ideally speaking, it is the distance which the nerve has to travel and the functional potential in the muscles. If it is there, even if 2 years have passed, still we can go for nerve transfer. So there is no hard and fast rule for time period, but as a general rule, 6 to 9 months is accepted. But always get an EMG done. If still there is a potential in the end organ and the distance is short, you can still go for a nerve transfer.
I would just like to repeat for emphasis. Am I correct in understanding that whatever the time period, if there is too much time period that has elapsed, you can still do a EMG, and if there is activity present, you can go ahead with the tendon transfer.
With the nerve transfer.
With the nerve transfer, sorry. Yes,
Yeah,
with
yeah,
the nerve transfer.
yeah.
Perfect. I think there is one more question. Is age a factor? Dr. Nayab is asking if is age a factor as well in considering timing for nerve transfer?
I think considering timing, age should not be a factor. Age should be an independent factor in deciding about nerve transfer. If, like in any nerve repair, age is obviously advancing age is not a good factor for complete recovery of the nerve. So age should be considered as an independent factor. And for timing, I don't think we should consider age as a factor.
I think in children, age is a factor if you are planning nerve repair, because then nerve has lesser time path to travel.
Yeah, I agree. I think in nerve transfer, you are already overcoming that issue, and so it should be taken as an independent factor. Age, it should not affect the timing.
Correct. So should we go on to the next speaker? Is the next speaker ready?
Before changing to the next, can I ask about Professor Mustashan about any critical criteria for selection of the patient to do nerve transfer?
Critical criteria, as we have already discussed, the indications for nerve transfer. I think each and every indication which we have mentioned is important, but the most important would be that if you have to put in a nerve graft for nerve transfer, then better go for tendon transfers. So I think primary repair, because the objective of nerve transfer is motor to motor coaptation. And if we still have to put a graft in, then probably we should not consider nerve transfer. Then it is better to go for tendon transfer if available. This is, in my opinion, one factor, but there could be any other factor which I think if
I mean the patient criteria, the understanding of the patient mentality, cooperative. That's what I mean.
Sorry, if you can repeat your
mean
question.
The patient cooperation and his understanding of the procedure, and any patient I will do or only select some patient.
Yeah. So I think if for any hand surgery procedure, we always select a patient who can understand the physiotherapist's command, who can understand the long recovery and the input required by the patient. So I think that is important for any hand surgery procedure, and more important for nerve transfer. If you think that your patient has low IQ, he cannot understand the synergistic action, he cannot understand your command, and he cannot follow the long pathway which is required for rehabilitation, I think for any hand surgery procedure, that patient is not an ideal candidate, and more so for the nerve transfers.
Thank you.
Professor Salah, this is Dr. Sabdar.
Yes, welcome, Dr. Sabdar.
How are you? So I would just say, I would just add one line to this, that if you are choosing nerve transfer over tendon transfer, the patient and the surgeon should have more patience than the patients itself. So it's about the patience, because you have to wait and you have to pray for the function to come back. It's never fixed that how much of the power you will get, but it should be a patient that follows you for over a year period of time at least. So this is also a criteria. Here we get a lot of patients for this, but their follow-up is so thin and so non-compliant that we come to the decision that we choose tendon transfer over the nerve transfers.
Thank you, Dr. Sabdar. This is what just I want to highlight for our junior colleagues. Sometimes you have to have a wisdom about when to do. Usually you say you have to know first how to do, then you know when to do, and then lastly when not to do. This is usually being able to do this. This is not the end of the story. Sometimes you do a big surgery and the patient IQ is not suitable for that, and the patient will drop from the follow-up, and everything is lost, and you expose the patient for surgery and long time and so on, and he will not be cooperative with you. So this is my point that I want to highlight.
Yes, but if you are choosing the one of these procedures, for example, tendon transfer versus nerve transfers. So in tendon transfer, you also need a lot of IQ from the patient because he has to kind of do that kind of a physiotherapy, and you have to re-educate his mind and whatever. In nerve transfer, that is less likely required, and is also required, but less likely required because the nerve has to grow and then some kind of functions come back, and then you have to re-educate the patient kind of. So this is also one of the indication or one of the priority that you choose nerve transfer over the tendon transfer. But if the patient is non-compliant and if the patient is low IQ, then you can't choose any of the procedure.
I agree with
We
you.
have decided on this point. I think it is very clear now. If there is any other point, we can discuss that, or we move to Zahra Altaf for the next presentation. Because we are running out of time and we are already 40 minutes past it. So over to Zahra.
Thank you very much, sir. Assalamu alaikum. Good evening, everyone. My name is Dr. Zahra. I am plastic. Sir, am I audible to the audience?
Yes, loud and clear.
Thank you, sir. Okay, so I am a plastic surgery resident in Mayo Hospital, Lahore. As we are running out of time, so without wasting any time further, I would just move to the second article, the review. So the second article today, which we have chose, is on laser. It's a comprehensive review article. We know that laser has a very wide application in plastic surgery field. Today, we are just going to discuss the laser management of hypertrophic scar. This article was presented. This article was published in 2020 from the Department of Plastic and Reconstructive Surgery of Johns Hopkins University. The main authors of this article are Dr. Kevan and Dr. Muhammad Asif. The author in this review has presented as brought light on salient points, which are the application of laser for the management of hypertrophic scar and how they were evolved, different type of lasers and how do they work, indication for choosing laser for the therapy of hypertrophic scars, perioperative considerations, and guidelines for the practice management. In the background of this article, the author has briefly described how hypertrophic scars are formed. These are basically all we know, that because of dysregulated mechanism of wound healing. Burn-related injuries are more prone to form hypertrophic scars. This prevalence is as high as 70%. We often see that hypertrophic scars are aesthetically unappealing. They may show signs of pruritus, pain, erythema, contracture formation, resulting in restricted range of motion. Management of hypertrophic scars ranges from non-surgical management to surgical management. Non-surgical management includes pressure garments, silicone gel sheets application, intralesional steroid or 5-FU injections, cryotherapy, radiotherapy, laser and light management. Surgical management, which we all have been practicing, includes scar removal and contracture release. The author has briefly described the history, how laser brought the subject for the management of hypertrophic scar management. It was first practiced by Anderson and Parrish. IPL laser was practiced for the management of hypertrophic scars. They first time introduced the principle of selective photothermolysis. Selective photothermolysis is basically when the laser light of different wavelength, shorter wavelength or the longer wavelength, targets the skin, hits on the skin, they target the specific target tissue, which may be chromophobes, which may be hemoglobin, tattoo pigments, or water molecules. When they strike on the target molecules, all the energy get absorbed by these target molecules, and they emit heat. This heat results in temperature, forms the temperature effects on the surrounding skin. Different temperature ranges, at different temperature ranges, different physiological changes occurs. The author has described that if the temperature of the surrounding skin ranges from 60 to 70 degrees, collagen and protein starts to denature. At temperature 70 to 80 degrees, cell membrane and nucleic acid denatures. If the temperature is raised further higher up, at 70 to 100 degrees centigrade, coagulation necrosis of blood vessels occurs. And if it goes further beyond that, above 100 degrees centigrade, the water within the tissue that vaporizes, separation of the planes occurs, and ablations occurs. He has categorized the scars in two categories on the basis of its appearance, its color, and its scar thickness. Scars showing signs of dyschromia include erythema, hyperpigmentation, scar thickness, atrophy. On the basis of these classification on the appearance of the scar, it simplified the design for the choice of laser management for the scar management. Laser types may include ablative, non-ablative lasers, fractional, non-fractional, vascular, and non-vascular lasers. Ablative lasers are those that target the dermal and epidermal layer of the skin. Widely practiced ablative lasers are pulse CO2 lasers and ER-YAG lasers. Non-ablative lasers basically do not target the epidermal layer, they directly target the dermis layer of the skin. With higher optical penetration, they go deeper in the skin layers and target the chromophores present there. But they spare the epidermal layer, but they have lesser efficacy. Fractional lasers are basically the balance evolved with time. It is basically a balance between the efficacy of ablative laser and the safety of non-ablative lasers. Fractional laser are basically the fractions of laser beams that are targeted on the skin. They result in selective photothermolysis. These targeted beams, these fraction beams, they form the microholes in the skin. These microholes are controlled width, depth, and densities with surrounding healthy skin appendages. These surrounding healthy skin or the unaffected skin become the source of viability for adding the regeneration or remodeling of the scar tissue. Non-ablative, this fractional laser element then was used for the development of further lasers. Non-ablative fractional lasers, they selectively thermalize the dermal layer of the skin. Temperature ranges from 50 to 70 degrees, and it is used for the management of mild to moderate hypertrophic scars. Ablative fractional lasers, wavelength ranges from 10,600 to 2,940. The temperature effect it causes in the surrounding tissue rises above the 100 degrees centigrade, and it results in the formation of vaporized columns. These vaporized water columns are basically are formed from the epidermal layer to the dermal layer. This epidermal layer and the epidermal layer, because we know that they use the mechanism of selective thermolysis, the microholes in the form of vaporized water channels are formed. They breach the skin from the epidermal layer to dermal layer. The surrounding skin then helps to promote the healing of the skin in a rapid time. This epidermal cells restore the continuity of the skin, and in the dermal layer, collagen remodeling occurs. Collagen 1 type is replaced with collagen type 3. Because the remodeling of collagen tissues, collagen cells occur, it results in it increases the pliability of the skin of the involved area. decrease the thickness of the skin, improves the molecular function. PDL wavelength for PDL ranges from 585 to 595 nanometers. Selective photothermolysis, it targets the tissue, and selective photothermolysis of hemoglobin occurs, which results in the coagulation of vessels. Due to the coagulation of vessels, tissue hypoxia occurs, and then collagen catabolism occurs in this kind of lasers. It penetrates the skin less than AFRs. Mechanism of PDL help reduces the vascularity because it coagulates the vessels present in the hypertrophic scars. By coagulating the vessels, it reduces the erythema, signs of pruritus, pigmentation, and hypertrophy. Now, PDL and AFR laser are two types of laser therapy that have shown greatest efficacy for treating the hypertrophic scars. Then the author has quickly reviewed the comparison between these two lasers. As we have discussed that ablative laser acts on epidermis and dermis layer of the skin, and non-ablative PDL laser, it acts on the dermal layer of the skin. Ablative laser targets the water molecules present within the tissue, and PDL laser targets on the hemoglobin. Ablative laser regenerates from because it is ablative, it targets from epidermal layer to the dermal layer. It regenerates epidermal layer and remodels the collagen present in the dermal layer. While the PDL laser results in tissue hypoxia and collagen catabolism. Ablative lasers, FCO2, are helpful in improving the pliability, texture, and thickness of the scar, while PDL laser reduces the erythema, signs of pruritus, pigmentation, and pain. Ablative lasers are more suitable for thicker, mature scars, while PDL lasers are suitable for immature scars having width of less than 1 centimeters. So the author has said that it is advisable to start laser therapy as early as possible. Initiating the laser therapy as early as possible following scar or surgical excision. When the sutures are removed for the first time, he has advised that if we start the laser therapy at that time, it shows better results for the scars. In his review article, he has described that 1 to 9 sessions, 4 to 3 months apart were planned, which decrease the symptoms and decrease the contracture and increase mobility and overall rehabilitation of the patient. So in Johns Hopkins University, they chose these two, PDL and AFR lasers. For PDL laser, they chose Syneron Candela PDL machine. Settings were made according to wavelength 595 in PDL, and pulse width was set on 1.5 milliseconds. Pot size of 10 millimeter with width of 20 to 30% overlap was designed. These are the different settings of the laser machine, which they designed for the target therapy. For different skin types, Fitzpatrick type 1 and 2, fluence of 6 joule per centimeter square was fluence energy of 6 joule per centimeter square was given. For Fitzpatrick type 3 and 4, 5 joule per centimeter square was given, and for Fitzpatrick type 5 and 6, 4 joule per centimeter square was given. For FCO2 AFR laser, ultra pulse lumens machine was used. This machine had 3 hand pieces, active, deep, and scar FX. Active had the lowest energy and highest density. Scar had the highest energy and lowest density. And deep was the balance between these two. So the settings of deep energy was 30 millijoule was set, and density around 5% was set. In pre-op consideration for selection of for the therapy, there were few pre-op considerations. According to Fitzpatrick type skin, the author has said that with higher skin type, Fitzpatrick skin type, higher skin types, we know that they have more skin pigmentation, more post-inflammatory hyperpigmentary responses were seen. So the effluence energy for higher Fitzpatrick skin types was set on a very lower setting. And with those with lower skin Fitzpatrick skin types, fluence energy was set very high, as we have discussed in FPDL settings. Patient having the history of chronic pain, any medication history for any history of taking medication for pain, that advised the plan for the management of pain management during the procedure. These patients who had the positive history for any kind of neuropathic and chronic medication for pain, they used topical anesthesia or sedation or full anesthesia. PDL usually do not requires any kind of anesthetic management during the procedure. Infection are usually very rare after these procedures, but patients having history of viral infection were given antiviral therapies. Type of the scars, if the scars were mature or immature. For mature scars, they preferred AFR lasers, and for immature scars, they preferred PDL lasers. Post-operative care were petroleum-based ointment were advised on the day of the procedure every 2 to 3 hours for 2 to 3 days till the epidermal epithelialization occurs, and then moisturization for next 6 weeks. Avoidance from sun exposure and high intensity light were advised to the patient. Application of sun screens and compression garments were advised. This is the first case. The patient, she was 4-year-old patient with superficial thickness scalp burn. The scar was very hypervascular, so they used 2 sessions of PDL to reduce the vascularity of the scars, and then later on FCO2 3 sessions were given. This is the scar appearance. This is the case 2. We can see in the tablet that there's a deep thickness, partial thickness hypertrophic scar was formed. PDL 4 sessions were given prior to FCO2 sessions that reduced the vascularity, and then thickness was reduced with FCO2 laser sessions. This was the case 3. Deep partial thickness grease burns, scars. PDL treatment for 3 sessions to central portion. Concurrent therapy was given. PDL 3 treatment session to the central portion because it was very vascular, and the periphery were given 3 treatment session of FCO2 lasers. And then the result, we can see that overall vascularity and appearance of the scar had improved. This is a case 4. Again, patient had history of deep facial burns, deep partial burns. PDL 4 treatment sessions were given to reduce the vascularity, and then FCO2 4 treatment sessions were given to reduce the thickness of the scar. This is the post-operative results. So these lasers decrease the scar thickness. As we have seen the results, improve scar pigmentation, texture, pliability, signs of pruritus, neuropathic pain, contracture, need for surgical incision, function and quality of life. The author has concluded the article that pulse dye laser therapy and ablative laser fractional resurfacing laser are the two types of laser that has been used to treat the hypertrophic scars. These treatments have shown to decrease scar thickness, neuropathic pain, need for surgical excision, as well as improved scar pigmentation, erythema, pliability, texture of the skin, height, and pruritus. The limitation of this article is that long-term follow-up, patients were not followed beyond 12 months. And then due to different reasons, patient lost to follow-up or the long-term follow-up was not done. There are very limited number of cases been discussed. Dimensions, we don't know the dimension at what, how wide the scar was for which they chose for the laser therapy. Timing of the session, that at what stage they started this treatment sessions. Surface area per session, that how many surface area was targeted in one session, or the overall wound was, overall scar was given in the sessions, or intervals at what time each session was given. In the beginning of the article, they have described that timings were set 1 to 9 sessions at 4 weeks to 3 months apart were given, but we don't know in individual cases that how much time interval was set. This was all in this article. Any discussion or question is appreciated.
For starters, is your name Zahra or Zara?
So it's Zahra.
Zahra, okay. Thank you, Zara. Thank you very much for, I think you did a very nice analysis of the article as well. Apart from presenting the facts and the review, your analysis was very much appreciated. I'll ask my question in the end. Okay. Let's go to the questions in the chat. What would be the regime for following the PDL and CO2 laser? On alternate basis, and how quick can the sessions be
started? In this article, it's not been discussed that what was the regime selected. On the basis of just on the appearance of scar, the author has said that the scars showing more signs of vascularity or redness, erythema, they were given PDL. And then those scars that had shown the signs of or having thickness, more thickness, they were given AFR sessions. All the cases discussed, they were given PDL session before giving the AFR session, because PDL is for the treatment of immature scars.
I think the most important key message of this article is that it all depends on the timing of the scar. If the scar is in early, that is in it is hyperemic, pruritus is there, and it is red, and patient has presented early, then you always start with PDL, and then followed by fractional CO2 laser. And if patient presents late and there are no signs of erythema, pruritus, neuropathic pain, meaning thereby that relatively mature scar, not a fully mature scar, but still it is hypertrophic and raised, so then probably we can right away go start with fractional CO2 laser. So it is all depends on the stage of the scar, and that is one key message of this article.
Yes, because PDL targets the hemoglobin, so vascularity is in the early stages of the scar.
Was there any comparison between these methods of therapy and the other methods, like with laser and without laser? Because he's always, or as I understood from the article, that he is using a pressure garment for all patients. He's giving the same care of the scar for all patients. Did he studied with laser, and there was a control group? And again, how long the laser was used, for how long the session? because to the best of my memory, that it was 3 or 4 sessions or up to 9 sessions, I think, like with 3 to 4 months. So if I give patient 3 sessions for 3 months, it will be almost 9 months. It will not be before 1 or 2 months before burn. So he's almost up to 1 year, right? So most of the hypertrophic scar, according to my experience, many of the patients with hypertrophic scar within 1 year, 1.5 year, all the manifestation of hypertrophic scar are settled. With pressure garment only, most of them are settled. So what is the benefit to add laser? Is it if I can't have a superiority, at least I don't have non-inferiority like for treatment with the other modalities. So I cannot. Can you clarify that?
Yeah, thank you very much. I think a very pertinent observation, and you have picked up a very important point. I think by far, after reading this article, I think so far the best indications for hypertrophic scars are immature scars which are hyperemic, erythematous, and which have neuropathic pain. I think in those scars we usually try. If the scar is large, we are unable to inject them totally in whole of the scar. So I think those are the best scars, and they are best treated. They can be treated with PDL. That is the biggest advantage of using lasers in burn scars. And that is the true indication where I think there is no controversy and the benefits are always there. As regards relatively mature scar or the scars which have passed 6 to 9 months and which have their own course of maturation, and we are using fractional carbon CO2 laser, I think that needs to be clarified, and for that probably we need to have further studies where we can compare the fractional CO2 laser maybe at 9 months of scar age with fractional CO2 laser and without fractional CO2 laser, and see how does it improves the appearance of the scar. Having said that, one of the indications in this article they have used is that they have released the scars, they have done multiple Z-plasties, or they have done other V2Y plasties, or they have released the scar by local tissue rearrangement, and they have started this fractional CO2 laser immediately after that local tissue rearrangement, and they have shown that the recurrence of in those scars is less. I think this point also needs to be further clarified, that we can design a study where we can do local tissue rearrangements to decrease tension on the scar, and in one group we can apply a CO2 laser, and in another group we treat them as such without CO2 laser, and obviously then we will be better knowing the effects of fractional CO2 laser. But I think the PDL laser in early stages of scar is definitely beneficial.
Also for the treatment of pruritus, if anyone have experience, because I am facing this too much with my victim patient. I have in my center a lot of patients with major burns that it reach up to 80% and 90%, and thanks to Allah, these all patients are surviving. But what I'm facing after the healing of this patient and after they survived, I'm facing the intense itching and the pruritus. And actually, it's not responding. I tried everything. I'm sending them for the neurologist to prescribe this pregabalin and gabapentin, Lyrica, and so on. But sometimes they're responding and sometimes relapsing after that. And even the pruritus is persisting after the erythema even subside, and the wound is a scar becoming mature, but still the itching is persistent. Anyone have experience about the treatment of such patient?
Mustafa, you need to unmute yourself. Mustafa, you are muted. Mustafa, you are muted.
Yeah, sorry. So I think in mature scars, if itching is still there, I think then that it is only supportive treatment. We don't have any magic bullet to treat coaching in mature scars, but obviously in immature scars, I think PDL is worth trying.
What about Botox injection?
I haven't any experience of using Botox injection in such scars, but probably the mechanism is related to mast cells overactivity, and I don't know how Botox is going to affect the mast cell activity.
No, actually, they are not in the late stage. It's not related to mast cells. Usually, it's related to the nerves. It's a neuropathic pain. This is why they are trying to do neuromodulation with Botox or something like that. There is some articles about that, but actually, I didn't try it because
Interesting.
Okay, anyone of the audience have any extra questions?
Zara, my question to you, which has already been partially answered, is that after going through this article, what do you think are the priorities that need to be investigated in a further study? If you want to take this further, how would you formulate a study? Which aspect would you like to study?
Sir, the points which I have already described in the limitations, I would like to bring light upon that. First of all, as the audience have asked us the question that the timing of the laser, what kind of treatment we design at the scar presenting to us earlier, and then the scar that presents to us later, and which kind of scars do we prefer to give simultaneous or concurrent therapies? In my study, if I do go through or to choose to study it further, I would like to see that in what kind of scars, how these laser therapy sessions they behave. And then whether we can give it to the whole body treatment, to the scars, if they are involving the full limbs, is it safe to give it to the widespread areas? Or yeah, pretty much it. Sorry, sir, your mic is muted.
Yeah, there are a couple of questions from Sebastian's side asking about clarifying that CO2 fraction used after proliferative stage in the maturation phase.
Yes, CO2 laser is used in the maturation stage where the scars.
Okay, sorry. Keep going.
Where the scars are more thick, greater than 1 centimeter, with thicker texture, CO2 laser is preferred.
Dr. Nayab is asking, what's the lowest age limit when lasers can be used in children like this?
In this article, he has reviewed the child of age 4 years to the age of 40 years. So I think there is no age limit is described in my.
Okay. What is the optimum interval between sessions? Has it been mentioned?
No, the intervals are not. We have already discussed in limitation. The intervals are not clearly described here.
Dr. Nayab has made a suggestion that we can, in a further study, compare triamcinolone with fractional CO2 for recurrence.
Yes. He, in this article, has reviewed that if we concurrently, simultaneously give the medication therapy, like if we do the laser therapy first, and then we apply these steroid or 5-fluorouracils on the scars, these medication are delivered better in the scars because the laser creates pores scar, and then its bioavailability in the scar tissue is more.
Okay.
and more importantly, scars become relatively soft, and it is easy to inject in those scars, because most of the complications of intralesional steroids is that the proper plane is difficult to find. Most of the people they either inject deep or more superficial, because it becomes difficult to inject within the lesion. So these lasers, they do help in softening the scars. I think that is one advantage of doing fractional CO2 laser in a mature hypertrophic scar, relatively mature hypertrophic scar where you want to inject intralesional steroids.
Usually, when there is a sick scar, usually the dermatologist pre-treat the scar with cryotherapy. This makes softening of the scar first before injecting triamcinolone. And sometimes also they combine triamcinolone and 5-fluorouracil. This give a good, very, very, very good result, especially for
Excellent.
not only hypertrophic scar, for keloid scar, if it is sick.
Yeah. So same thing I think with the fractional CO2 laser does, and according to the authors, I haven't experienced fractional CO2 laser followed by triamcinolone injection, but probably that works on the same principle.
Okay, Dr. Zara wants your comment that authors have mentioned different effects on how the tissue behaves to different temperature ranges. What are your comments on that? How did the authors measure the different temperature range and check the different levels of tissue reaction?
Sir, I would again open up the slide where the author has mentioned that at the temperature around 60 to 70 degrees, he has mentioned that protein and protein starts to denature. If the temperature goes further higher up, the nucleic acid starts to denature. If the temperature goes beyond 100 degrees, the separation of the plane or the ablation starts to occur.
Yeah, exactly. That's what she wants to ask. How did the authors measure these temperatures?
Okay, Dr. Zia, they haven't actually measured it. This is a basic chemistry knowledge on the basis of which they have tried to extrapolate that knowledge of denaturation of proteins to this. Actually, they haven't measured, I think, and it is based on the knowledge of chemistry, how at what temperature how proteins are denatured. I think it is based on that.
So these facts were not a part of this study. This was a previous fact that was mentioned.
Yeah, I think so. Yeah.
This is the basic science of laser and how it acts. This is studies on animal models and they affecting tissues for different temperature and to expect what is the response under microscope, light microscope, and electron microscope. What the changes happening in the cells.
Yeah. Thank you very much, Professor Mustasan and team Mayo Hospital. I think you have done a fantastic job and made us wiser on these two issues, which are very, very important issues. Thank you very much.
Thank you.
And we look forward to the Journal Club, which I'm not sure which team will be
next month, inshallah, Alexandria University from Egypt was Dr. Hussein Saber and his team, Professor Dr. Hussein Saber Abul Hassan and his team.
That's fantastic.
Thank you very much. Thank you very much, and my special thanks to Professor Salah, because he has kept this Journal Club alive, and he has raised such important points which have made all of us, at least myself, very wise, and I'm really grateful to Professor Salah for such valuable comments. Thank you very much.
Thank you, Dr. Musashan. Thank you, Ramiz, and thank you, Dr. Zara, and thank you for all the audience. And if anybody has any comment, otherwise we can close, and because we are almost in time now.
Thank you very much.
Thank you. Bye-bye.